Hello, I'm Geraldine Moses. Welcome to the program Psychotropic Drugs, What's Safe and What's Not. We've come a long way since the 1940s when psychotropic drugs revolutionised the care of the mentally ill. They've virtually become first-line treatment of mood and behavioural disorders. And in recent years, there's been a wave of new psychotropic drugs developed. But being new, we need to be aware of the safety issues that are associated with their use. And the risk of medication misadventure is often higher with psychotropic drugs. So our program looks at antidepressants, mood stabilisers, anxiolytics, hypnotics and antipsychotic drugs. We'll examine the issues related to their toxicity, interactions, overdose and monitoring for adverse effects. We'll also consider the use of psychotropic drugs for special populations, such as children, pregnant women and the elderly. So we're coming to you across Australia through the Rural Health Education Foundation satellite network. There are a number of useful resources available on the Rural Health Education Foundation's website, which is www.rhef.com.au. So, now let's meet our panel. Dr. Anthony Harris is a senior lecturer in the discipline of psychological medicine at the University of Sydney and a consultant psychiatrist for the Prevention, Early Intervention and Recovery Service. Welcome, Anthony.
Good evening, Geraldine.
Christine Culhane is a pharmacist with 20 years' experience in mental health, including specialist roles in psychiatric inpatient and outpatient settings. She currently manages the Psychotropic Drug Advisory Service on the telephone in Victoria. Welcome, Christine.
Hi, Geraldine.
Chris Alderman is the Director of Pharmacy at the Repatriation General Hospital in South Australia, and he's also Associate Professor of Pharmacy Practice at the University of South Australia. Welcome, Chris.
Hi, Geraldine.
And Dr. Jonathan Isles is a general practitioner with 19 years' experience initially in solo practice and then for the past 9 years in a group medical practice in suburban Hobart. He has an interest in geriatric medicine and sports medicine. Welcome, Jonathan.
Good evening, Geraldine.
So, to begin this important show, let's have a brief overview of what psychotropic drugs are. Like, is there a definition and what are the safety issues? So, Chris Alderman, I wonder if we could start with you.
Sure.
Is there a definition for what psychotropic drugs are?
Oh, Geraldine, there are lots of definitions and I guess you read different ones, but the one I thought best described what psychotropic drugs are the drugs that we use with the intent of influencing thoughts and emotions. So I suppose that's a definition that allows us to think of some drugs that under certain circumstances wouldn't be regarded as psychotropic drugs, in a different context can be regarded as psychotropic drugs.
For example, do you mean analgesics?
Well, analgesics, I guess, are probably one that can have psychotropic effects, but I'm thinking more along the lines of things like mood stabilisers, anticonvulsants, for example,
right,
that we use for different therapeutic applications elsewhere.
And so what do you think are the issues that are developing in this area in terms of safety?
Well, what we've seen, Geraldine, since the early 1990s is an absolute explosion in the availability of psychotropic drugs. There's so many more different agents available, and we're really still on a learning curve about these medicines. We're still understanding an evolving picture of their safety profile, how to use them best, how to use them in combinations, and to be aware of the interactions and the problems that we only see when these drugs are used in a large-scale post-marketing surveillance phase. And I think that's really something we're all still coming to grips with.
And I wonder, Anthony, if you could comment on this as well. Like, we're saying what's safe and what's not. Amongst your colleagues, do you have these discussions about safety?
Certainly. And I think the huge increase in number of drugs is one of the problems. The tendency to mix and match, to combine too many drugs all together is a real problem in this particular field, and let alone the individual side effects. And
surely also the fact that clinical trials usually are for a short period of time, and yet in many of our patients we're using them for a very extended period.
These are drugs treating illnesses which are often long-term for the individual patients, and the trials are often narrow, and the populations in which they're done are quite unrepresentative sometimes, the clinical populations that we treat, yes.
So I suppose one of the issues we're dealing with in this area is the lack of evidence. They're often flying by the seat of our pants. But maybe we can go back to Chris now and just talk generally, if you like, about one group of drugs, say antidepressants. When we're looking at those, how do we choose between them as pharmacologists or people interested in pharmacology in terms of what's safe and what's not?
Well, there are some general rules that we can apply and think of when we're choosing antidepressants for an individual patient. We know, for example, that major depressive illnesses and many of the other illnesses we use antidepressants for are chronic relapsing illnesses. So we know that medications that worked last time are probably not a bad choice to use for this occasion if everything else is equal. So that's one of the issues we take on board. We think about the other medical conditions that the patient might be affected by. We think about other medicines they might be taking at that time. We think about things like suicide risk, cost and convenience to the patient. It's really ideal if we can get a drug that can be taken, you know, one dose once a day. It's a major advantage for our patients because no medicine can work unless it's being taken.
One of the other areas, issues that's affecting the use of antidepressants is that new ones are coming out all the time, and yet we're still using some of the ones that came out in the 1940s and 50s. Do you see any safety issues in using the older drugs?
Well, all of the drugs have their own safety issues, and it's important for us involved in using them to be aware of what they are, make ourselves familiar, and to accommodate that in the way that we use the drugs and to monitor the patients in such a way to allow us to be aware of issues as they arrive and to address them proactively with the patient. Making the patient their own advocate, of course, is another important strategy that we can employ so that people can, if you like, advocate on their own behalf in interactions with the health professions.
That's right. And just generally speaking, Jonathan, are there issues with antidepressants in your practice that you see coming up all the time?
Sure. Well, I don't want to say my practice, but but one of the things that I fear is that GPs have, over the time that these new agents have become available, have got the feeling that these are so much more safe than their older cousins, if you like, or the parent
like
drugs.
monoamine oxidase inhibitors. Exactly,
which now maybe for some young GPs have not, they're not even been experienced enough to know what the old monoamine oxidase inhibitors do and what side effects they have. But nonetheless, even the newer SSRIs, the thing that I fear is that we tend to use them in a set and forget sort of mentality a lot of the time. Ensuring the right diagnosis is one thing, and making sure we have links to our specialist colleagues is important. But I fear that sometimes we use these drugs because they're new and because we get the feeling that they must be safer if they're newer and that they must be more effective if they're newer. I think they're things that we can get concerned about.
Yes, that's right. Well, we're now going to talk about some special populations, so perhaps we'll move to our first case study. This case is Jane. She's a 35-year-old woman, and she was diagnosed with postnatal depression following the birth of her daughter 3 years ago. Back then, she was prescribed fluoxetine, which was stopped after a year of treatment. But Jane is pregnant again, and she's now in her first trimester and concerned about taking antidepressants during pregnancy. And she's thinking about taking St John's wort instead of a prescription drug. Now, this is a not uncommon scenario, isn't it? So I wonder if we can talk to Christine about the sorts of questions you get on your drug advisory line about drugs in pregnancy, and you can give us some guidance on what's safe and what's not.
Okay. Jane's probably fairly typical of people who ring up. People ring up and they want to know, is it okay to take this drug in pregnancy? Sometimes they're pregnant already, so it's a knee-jerk sort of reaction. Oh, I'm pregnant, I'm taking drug X, what do I do now? And other times it's, I'm planning to become pregnant and I have a history of this, or I am taking this, how safe will that be? What if I become sick? Can I take this medication safely? What's it going to do? And I think somewhere in the scheme of things that they need to not lose track of where am I in terms of my illness in this process, because if you're not actually actively unwell at that point in time, you just need to put in safeguards along the way to make sure that you stay well and that it's monitored.
So generally for this patient, which would be the class of antidepressants which would be considered safest during pregnancy?
Look, Jane has responded to fluoxetine in the past. SSRIs are generally fairly safe in pregnancy. I probably wouldn't advocate St John's wort, and I probably wouldn't advocate anything to be taken in a preventative way when she's not actively depressed.
But is it also because of the lack of safety data with the St John's wort?
There's very limited information with St John's wort. There is nothing to suggest that it's a problem. There's nothing to suggest it's safe.
Which is often the case in pregnancy, isn't it?
Which is often the case with all of our medications.
Yes.
Exactly. So we fly by the seat of our pants a lot of the time,
yes,
but knowing that we've got very limited information to work from. You tend to know very, very quickly when something goes wrong, not so quickly when things go right. We do know that the SSRIs in general are fairly safe, and given that she's used fluoxetine, you would give it some serious consideration. I guess the downside up front would be that it hangs around for a long time. So if something does go wrong, you can't get rid of it in a hurry.
And what about...
And you've got the risk of accumulation in the
newborn?
fetus.
That's what I was going to say. What about when she gets close to delivery and the issues?
But it's not just that. It's also that fluoxetine, because it does hang around a lot longer, tends to cross the placenta at a slightly higher rate than the other SSRIs. So there is the risk of increased exposure as well.
Could you please also comment on the recent safety data on paroxetine, because haven't some people suggested that it's teratogenic?
There's evidence to suggest that there's an increased risk of cardiac septal defects with paroxetine. There certainly is an increase over the normal rate in the community. Again, that risk is relatively low, but the safety data would need to be weighed up against the person's need at that point in time. It's not enough to say don't use it, because that's not always right. You need to weigh it up against the mother's relative risks at that point too, because doing nothing when someone is seriously depressed during pregnancy also carries its own dangers.
Yes, which we know in all sorts of conditions. Chris Alderman, I believe you wanted to make a comment about the antiplatelet effect that SSRIs have in pregnancy and the safety issues there.
Well, I guess it's a wider issue, Geraldine, but certainly these are drugs that are known in some cases to interfere with platelet aggregation, and there's wide-scale pharmacoepidemiological data now evolving to tell us that they increase the likelihood of bleeding in all kinds of different circumstances. If you look through the fine print of the product information, you'll find all kinds of references to things like epistaxis and menorrhagia and bleeding hemorrhoids and purpuric rash, and you can go on. Some people hold concerns about the use of SSRIs late in the third trimester because they believe it could contribute to increased perinatal complications relating to bleeding.
But are you suggesting that they come off the antidepressant?
Look, I don't think that's a call you can make in a general sense. I
Yes.
think that's something you need to think about in an individual sense with each woman and each child to be. And so it's really a case-by-case analysis, and really depending on how sick that lady is at that time, that would guide our thoughts about this. And bearing in mind also, if we're not talking about fluoxetine, perhaps if we're talking about another SSRI, the last thing we really want to have happening is complicating the parturition with a discontinuation syndrome as well.
Yes. Jonathan, you're rigorously nodding your head.
I'm itching to say something here. I think this lady's very interesting because there's lots of scenarios that could be the real case, insofar as she may be already taking St John's wort and she's fallen pregnant. Will she tell you? Will she not? Is she too embarrassed to say? Let's assume that that's a big issue in itself. But I think that the major issue from a general practice point of view is that we see these sorts of people coming along a lot, where they need a lot of reassurance that what did happen previously isn't necessarily going to happen, or if it is, that we'll monitor it and that we'll know what to do at the right time. It may be that, as you say, the fluoxetine, one of the things that I'm keen on is for each person to have their favourite sort of medication in each particular class. And it may well be that a GP out there sort of says, well, I don't use fluoxetine, I use something different. So it's important to know what the different SSRIs do in pregnancy. I think the shorter acting ones may be of benefit in terms of getting people who become depressed during a short period of time undepressed a lot quicker than maybe fluoxetine might,
Yes.
which sometimes has a long duration of action.
Well, I'd now like to maybe raise the issue, and Anthony, if you wanted to complete some comments about that, but I wanted to say, what if this patient is not just depressed, but she's bipolar? And then we have to look at the issues of perhaps using lithium or mood stabilisers in pregnancy.
Well, just to make some comments on the discussion earlier, I think this comes back to a risk-benefit analysis, which will be a recurrent theme for the evening. Just starting somebody on any medication during their first trimester when there's no clear indication is something that I think we'd all avoid. I think one needs to keep into account the depression, the severity of the depression that the lady experienced. If this was a mild depression before, she has no symptoms at the moment, it's quite clear that we'd be looking at supportive work, perhaps some cognitive behavioural therapy as delivery dates come close. But if this lady had a very severe depression, or in fact perhaps had bipolar disorder, then we'd be thinking again about that risk and benefit analysis. So, coming back to your question, Geraldine, about if this lady happened to have bipolar disorder, then perhaps starting on a mood stabiliser, if she'd had a history of relapse or of severe illness immediately after delivery, is a real possibility.
But this family of drugs don't look nice in pregnancy.
No, it doesn't, and I think one would think about perhaps using lithium, not during the first trimester, but later on in the pregnancy, keeping in mind the difficulties that might occur during delivery and thinking about the rapid fluid shifts and lithium being a salt, which can be a complicating factor.
How frequently would you do lithium levels during pregnancy?
I think you would want to do them more frequently than one normally does.
Once a month? Once a week?
As the dates become closer and closer, yes, and increasing frequency.
Right. And you were saying earlier that lithium's not as big a problem as we used to think in pregnancies, in terms of it being a teratogen?
Yes, I think that's true. The more recent information suggests that the risk is going away from lithium and is perhaps much more an issue as far as teratogenic effects with the mood stabilisers, which have been used perhaps more widely in recent years.
So can you be more specific? Do you mean sodium valproate?
Sodium valproate in particular, which has become really quite a very commonly used mood stabiliser, is now recognised as having quite significant teratogenic effects.
Yes. Now, is carbamazepine being used much as a mood stabiliser for bipolar disorder?
No, it's not. It's falling out of favour. Perhaps lamotrigine and some of the other anti-epileptic drugs are being used, but certainly lamotrigine would be being established as an important mood stabiliser.
Right. And we are unaware of any antifolate effects or spina bifida association with lamotrigine, are we?
As far as I'm aware, there is very little detail, very little data about the birth of children in this particular
it's
cohort,
hard, isn't it,
even from women with epilepsy.
Yeah, we have no spare people to practice on, do we? So it's so hard to know what the safety
Yes.
is.
Geraldine, if I might say, that one of the interesting things that I've just heard, of course, is that things change. So once again, the old adage of the old information is old information, and that you need to keep up because the paroxetine issue is now obvious. The lithium thing that we all said stay away from may not be quite so harsh. So obviously in the future these SSRIs maybe become much more mainstream. So
it's very true. Great point. Thank you very much, Jonathan, because information changes so quickly, particularly in this area, isn't it? Now, so perhaps we'll move on to our next case, which is sort of Jane grown up. We now have a 60-year-old woman whose name is Anne, and she used to have bipolar disorder. And she was taking lithium for 25 years, but was ceased off that 2 years ago. We don't know why, but she was, and she's been fine ever since. But lately, she's been tired, depressed, and has had trouble sleeping. So she now presents to her GP to ask whether she should require an antidepressant. So Jonathan, I wonder how you would approach this woman with a history of bipolar disorder, because aren't a lot of the antidepressants associated with triggering manic episodes?
Well, exactly, and well, that's what that's what we understand. The issue with Anne grown up is that we have some symptoms that could be some other things, and if she presented in general practice, first of all, deciding that she was depressed was maybe what we come to, but prior to that, we would maybe rule out a lot of reversible causes. The fact that she stopped her lithium 2 years ago could possibly be that she has some resultant effects of that. She could be hypothyroid in this case, for example. So I think that reversible causes are really important. But after that, if I'm coming to my diagnosis of depression, then I guess I'm coming to that stage where I'm going to have to say, oops, what happens if I put her on an antidepressant that might stimulate a manic episode? So I'm not confident enough maybe to just bung her back on lithium, even though Chris has mentioned that often things that work before work again. I have heard in the past that patients have told me from their psychiatrist in the past that, oh, if you come off lithium or having been on it, it might not work well the next time. So I think at this stage I'm going to ring my colleague who just happens to be sitting
Anthony.
doing nothing down the road.
And there's a slot available.
And there's a slot available.
Extraordinary. What your patients have been telling you, it's not completely correct, I suspect, but certainly there is strong evidence that particularly the tricyclics can trigger a manic episode if started in the absence of a mood stabiliser. The evidence is far less strong for SSRIs about that, but I think if this lady has had a history of responding to lithium in the past, and the pattern of her illness would suggest that she has the mood stabiliser lithium has helped her. The first protocol would be perhaps to start her back on her lithium. Lithium has a mild antidepressant effect. We may be seeing the beginning of another cycle of mood instability, and so that would be a very safe way of beginning an antidepressant treatment, but also if added antidepressant therapy was required, you'd be much more confident about introducing an antidepressant later on with the mood stabiliser on board.
So thank you very much for that. And I ask you back, what about one of these more modern mood stabilisers that actually has maybe an antidepressant action like olanzapine? Should I put her on that instead?
Again, it becomes a matter of risk and benefits and something for your individual patient. The newer mood stabilisers, the antipsychotics, olanzapine or quetiapine, both of whom have been approved for use in bipolar disorder, they have their own run of significant side effects. And if lithium has treated this lady well in the past and she's familiar with them, I would suggest that would be the first port of call.
Thank you.
Okay, well I propose that this lady, Anne, not only is suffering from some symptoms of depression, but also anxiety. Mm-hmm. And sometimes we see in practice now antipsychotics like olanzapine being used to treat anxiety. What is the evidence to support that?
It's not huge for anxiety. As you know, olanzapine is only indicated for psychosis and bipolar disorder at present in Australia, but it has been used over a very broad range of psychiatric illnesses, as in fact the first generation antipsychotics were 20 or 30 years ago.
Large
like
actions.
Largactil, yes, that's right. Yeah, trifluopyridine, stelazine was used in many different patients, as was thiridazine Mellaril.
Right.
So there tends to be and this is true across the board for psychotropic medications, they tend to jump the categories. So the antidepressants are certainly not used just as antidepressants. So for this lady, again, I think the balance of side effects would suggest that perhaps using an SSRI would be less likely to cause some of the problems of weight gain, which are commonly a problem with some of the antipsychotics, or the undue sedation, which might be a problem for Anne.
What we often see in this sort of patient is that she'll end up on polypharmacy. And she may even be, as time goes on, be on an antidepressant and a mood stabiliser and an antipsychotic. Mm-hmm. Would you like to comment on the prescribing of multiple psychiatric medicines? And then I'd like to ask Christine to talk about drug interactions.
Yes. Polypharmacy is a real issue. The temptation with so many of these patients is when something hasn't worked to add something on top in case that will also will just push along the process just a little bit. I think the more sensible clinical course is to say, that hasn't worked, I will now stop it, ceasing it slowly, not wanting to stop something too rapidly, and then trial another medication, a different medication which has some evidence behind its use. So rather than add more medications on each time, it's important to take stock of the situation, and I would suggest stop a medication before starting.
So keeping it simple and avoiding polypharmacy. Actually, just before we move on to drug interactions, we have had a question from a pharmacist in North Queensland, Marissa Pillar, who asked about the switching of antipsychotics from one to the other and the difficulty in knowing how to do that. Do you have some general guidance on how to switch from one antipsychotic to another?
Yes. Most antipsychotics can be switched over, one being tailed off when the next one is being slowly started. It really depends a little bit upon how acutely unwell the individual patient is. If they're very psychotic, that process is going to be quicker than what you might otherwise do. The difficulties really occur in a number of situations. One in which you switch from a high dose of antipsychotic and then you choose a relatively low dose of the next antipsychotic.
Right.
Sometimes when choosing from one medication to another, it's hard to know the relative dose potencies of these medications, and you end up underdosing or possibly overdosing the patient on the new medication. The other one is, major one, is when you go from a sedating antipsychotic to one which is not sedating. and the patient is generally very thankful for that they're not so very sleepy. But that can be alarming, or some behaviour can come through in a patient who's no longer as sedate as they were before.
Right.
There are some individual difficulties, one or two, but they're the two general situations.
Chris, you wanted to comment?
If I was just add one other point in relation to the so-called cross-taper. The other issue that we're dealing with now, of course, is the notion of long-acting risperidone injection and the introduction of the Risperdal Consta. And I think it's really important to make the point that the full effects of Consta really aren't going to be evident for 5 to 6 dosage intervals after the introduction of the drug. So we're talking 3 or 4 months. So there's really a need to continue the initial antipsychotic therapy that you've started with until you've gained some of the effects of the long-acting risperidone and they've become more evident. So that's an important point to bear in mind, and it also, of course, brings us back to the notion about when you start a long-acting antipsychotic drug. Very important to emphasise we don't kick off with one of those. Always oral first. Always oral first.
Can you just give us an idea of why you're mentioning that? I mean, in clinical practice, are you seeing people not waiting that period of time?
Well, I think the expectation is that they've had an injection, perhaps they've come back for their second injection a couple of weeks later, and people are thinking, well, I've got them stabilised and they've had no untoward effects, so it's now time to get rid of the first antipsychotic, and almost they're frightened of having 2 drugs going at once. So in an ironic sense, they're probably doing that patient a disservice by not continuing the first drug a little bit longer.
Although, if I could talk from a general practice point of view, we're not, bombarded is probably not the right word, but medical representatives and pharmaceutical representatives will give us the impression on all this range of new drugs that often, in particular with antidepressants, that you can stop one and start the other the next day. And I think that when you look at the guidelines, it's probably not true, and that's another reason that I get a little bit fearful about these things. So this crossover, you know, and to judge one side effect as being the old drug or the new drug is then once again undoing the therapeutic relationship perhaps that you might then otherwise have got. So very important.
I think this actually goes very well into the drug interactions issue, doesn't it? Because a lot of that might be really that the drugs are interacting on each other.
Absolutely.
So Christine, would you like to comment on that?
I guess drug interactions are a really interesting area because they're never absolute. There's always exceptions that make the rule. The thing about drug interactions is knowing which drugs are likely to interact and actually determining in a clinical situation whether this is a reasonable thing to go with or not, knowing that this is the interaction, whether it's serious or not, and if it is a potentially serious interaction, whether this is still an acceptable risk in this clinical situation. And if you do go with that decision, knowing what symptoms you're actually looking for as early signs that something is going wrong. So you need to make sure that the practitioner prescribing understands the potential interaction. You need to know that the patient or their carer actually has an understanding of what you're looking for and that they will seek early treatment if any of this occurs.
Right.
And if you can't ensure that safety, you've got to seriously think about whether this is an appropriate way to go. And it's relatively easy to get information on drug interactions that we know about. But there are still drug interactions that we don't understand or occur so rarely that we don't have enough information on them, and there might be drug interactions that haven't as yet occurred, and we still need to find out about them. So don't just exclude that from what's going on. You know, just because a patient comes in and tells you something that's never been said before doesn't make it untrue.
There's a question about the use of anti-anxiety benzodiazepines that perhaps I can direct to you, Anthony, from a GP in South Australia, asking whether there's ever a rationale for using more than one benzodiazepine in combination at a time in the same patient.
Very rarely, I'd have to say. Benzodiazepines have different characteristics according to their half-lives, so, but there's really not huge gain in
maybe it fits in with your message before about keep it simple, avoid polypharmacy.
Yes.
Right. Now on this point about drug interactions, I wanted to mention cytochrome P450. Anthony, in your specialty practice, do you guys talk cytochrome P450 language?
We occasionally intimate, though I must say that we're not full initiates into this particular arcane road. But I think the point is that if I see a new combination, and there are because of the increasing number of the psychotropic medications, there are lots of potential interactions. I just go and I check.
Right.
So it's the easiest thing to do.
Ring up the drug information people.
Well,
It's online, it's in
Yes.
guidelines.
Can I also say that for the GPs out there, they're sitting there in front of their desk, usually with a computer that actually is going to tell them what their interactions are. And I know from personal experience, and this is not a good thing to admit right now, that you sort of click that button as soon as it comes up, say, yeah, I know that one. But I think if you don't read it, if you don't understand it for your favourite drug, then you could potentially, there's a lot of cytochrome P450 system enzymes out there that we don't know in a general practice sense what they really do. We don't take notice of them. We do when it comes to throwing up a message in front of us on a thing, you know, don't use erythromycin with this or fluconazole with that. But that's about as far as it goes when it comes to different antidepressants.
Yes.
Yeah,
Chris,
I
did you have a comment? A quick quote, Chris
Well,
Alderman?
I was just going to say sometimes it's a matter of understanding the basis for the interaction, anticipating in advance and knowing what to do in terms of monitoring. And I thought you might be interested in an example that we had just recently, a person who came into hospital already taking simvastatin for their lipids. Somebody decided that this person needed a trial of fluvoxamine, Luvox, knowing that the Luvox is going to inhibit the 3A4, the enzyme that's responsible for simvastatin metabolism. We measured the serial CKs and watched them start to rise, and we said, no, this is a time to stop and think about something else, because we could see an interaction evolving and we were able to manage it. So that's an example of what can be achieved if you do understand the basis of the interaction.
Yeah, so I think that's probably the point, isn't it? We know that fluvoxamine is a potent inhibitor of these enzymes that cause drug interactions, so you could prioritise your concerns to those sorts of drugs. But one of the other priorities, Anthony, might be particular patients of ethnic backgrounds, because there's a lot of discussion, isn't there, that the genetic polymorphism that leads to different drug interactions here is from your ethnic background.
Yes, I mean, I think it's going into the area of personalised medicine, which is certainly something which is going to be coming our way. But there are certainly different genetic loadings for the different systems, not just for cytochrome P450. There's also definitely different susceptibilities to things such as extrapyramidal side effects, or even agranulocytosis from clozapine. So this is increasingly an area that we have to keep our eye upon as we learn more about the genetic variety, diversity within our population.
But it's real, isn't it? And
It is.
I suppose for our rural colleagues watching the show tonight need to think about Aboriginal susceptibility here. Do any of you have a comment along the lines about our Indigenous Australians and their sensitivity to adverse drug reactions?
Sadly, a very understudied population, and really not the research that's going to inform us terribly well in that area. But certainly there appear to be different susceptibilities. I should also mention there are different responsiveness factors amongst different populations as well. So some people do much better on particular treatments, and I think the future of some of this personalised medicine one day will be understanding a better basis for the genetic components of the illnesses, and being able to tailor the selection of the medicines in the direction that's going to give you the best result.
And avoid adverse reactions in the first place.
Quite possibly.
Fantastic. Well, why don't we move on to our next case study, which is a younger patient, Trent, who is 12 years old and he's depressed. His mother has brought him to the GP because she's expressing concerns about his mood and inability to get out of bed, but she's concerned that she does not want to use medication in young people. Now, Jonathan, you would have this sort of situation present sometimes, I expect?
Look, I have to say that apart from this case study, I tend not to see 12-year-olds who are depressed. But that's not to say that one might not walk in the door tomorrow. That's right. So I'd have to say that my gut feeling straight away would be to question the diagnosis or to understand what is the problem. I think that goes a long way to where our paediatrics psychiatric colleagues really do have an understanding here, and I think I'd be most uneasy in suggesting anything other than non-pharmacological therapy at this stage, and be asking for a referral. But I'd want to question the diagnosis. And at the end of the day, I'm always aware of the old adage of treating children in these sorts of circumstances, where you're sort of on your own.
Yes.
Nobody necessarily supports you, nor do they necessarily say you did the wrong thing. But I think getting some good information for mother. And another thing that I will say is maybe Trent is 12, but maybe he's a mature 12, and I think that the most important thing here is to see if you can actually get Trent to understand what his illness is.
Participate.
But I must admit, once again, I'm a GP. I'm going to handball straight to Anthony.
Well, Jonathan, I think some of your gut reactions are very right. The evidence doesn't support the use of antidepressants in 12-year-olds really anywhere near as strongly as later on in adolescence or in adult life. So the older you get, the more likely, in fact, the antidepressants are going to work. So that diagnostic clarification to look at not only Trent but his mum, the stresses in his life, look at what is happening for him is very important. But after that, the first port of call is definitely a psychological treatment. Cognitive behavioural therapy would be the treatment of choice for Trent, and some pharmaceutical interventions would be down the line.
I think one of the reasons why this mother might have been concerned about the use of antidepressants is all the information that's been in the media about suicide associated with antidepressants in its young population. Could you please assist us in understanding what this risk really is and whether any of some antidepressants are safer than others?
Yes, well, this has come out of the various investigations and trawlings of the pharmaceutical companies in their large drug trials with SSRIs. And I think the first thing to remember is that overall, the risk of committing suicide is far less after you start an effective treatment than before it. So in the trials looking at overdoses or self-harm, those rates are higher in the month leading up to starting treatment than in the months after.
Right, that's an important point.
Nonetheless, there is a small group of people who have, perhaps particularly with SSRIs, difficulty with agitation or perhaps akathisia secondary to those medications. And if that particularly affects the young person, then there is the risk that added agitation would lead to self-harm or a suicide attempt.
Now, some of our viewers tonight are out in rural locations who may not have access to the non-pharmacological therapy we were talking about, feel compelled to put the young person on an antidepressant. What advice can you give on monitoring for the risk of suicide?
Well, I think firstly it's important to be honest with both the parent, who's going to be worried and probably Googling the information anyhow, and the young person in question. So to say that your expectation is that this medication will help them, but there is this chance that for some people there's an increase in agitation or anxiety.
And if you saw that, would you immediately stop the medication?
Not necessarily. I think this might be one of the areas in which perhaps a short course of a benzodiazepine to help settle that agitation might be useful, or to half the tablet. So although the SSRIs have been marketed with a one tablet fits all, there's no doubt that sometimes it's half a tablet is the dose rather than a full tablet. So cutting the dose may be the appropriate way of dealing with that particular problem.
Can I ask a question then? If we move forward in Trent's life and make him 19 or 21, is the same risk of suicide still there?
Now, the problem with treating depression is that the risk of suicide is always there.
Is always there.
And that's an unfortunate but important fact to recognise. And so the risk assessment must be part of what you're doing. Not only are you looking for the symptoms of depression, but you're also asking questions about thoughts about self-harm. Have they thought about any techniques that they might use to hurt themselves? Have they got comorbid substance abuse problems? Have they had a past history of trying to hurt themselves? So getting an idea about the risk, and that also helps form a plan for how you're going to treat that young individual. What other resources you'll pull in, family, friends, how many tablets you give, you write on the prescription. And certainly there's no doubt that SSRIs are safer in overdose than the older tricyclics or venlafaxine for that matter.
Do we have a black box warning these days on these things? And if so, do we have an age limit?
There's certainly a black box on the SSRIs.
It was one of the first classes to get a black box, I think, wasn't it, in Australia? Chris, did you have a comment?
Oh, just on the epidemiology of suicide, I guess, in Australia. It's a sad thing to have to study, but it's important to note that it's really changed quite a lot since the introduction of some of the newer, less toxic drugs. The majority of suicides that complete in Australia are in fact self-inflicted violence, hanging yourself, shooting yourself, jumping from heights, followed by carbon monoxide poisoning. Drugs are a distant third, and the drugs that are used tend to be oftentimes non-psychotropic drugs, street drugs, analgesics, anticonvulsants, those sorts of things. So the things to watch for have probably changed in some ways as well. The other thing I'd just point out, I guess, is if you're dealing with somebody who's at very high risk of suicide during their initial period of treatment, the place for them to start is in hospital.
Yes. Well, on that cheery note...
No, but no, I think there is a cheery note.
Oh, good.
With the increased use of antidepressants, the suicide rates that had been going higher and higher through the 90s have actually turned and have been trending downwards over this decade. So the increasing use of antidepressants is probably having an effect.
Well, our next case study examines psychotropic drugs in the elderly. Amy is an 83-year-old woman who is a resident in a private nursing home. She's on rivastigmine for mild dementia and she's been on warfarin for some time. Due to behavioural problems, she was recently prescribed risperidone. Since then, Amy has been complaining of sleep problems, trouble falling asleep, frequent waking, nightmares, nocturnal leg cramps, and she's wandering around at night hitting other patients. She's also been incontinent of urine. So, Jonathan, this is one of your patients. It's not an uncommon scenario, is it?
No, I probably get a call to a nursing home once a week for fairly similar problems. And whilst they aren't all on rivastigmine and warfarin and risperidone, in actual fact, a lot of them are on risperidone after I've been to the nursing home because the nursing staff are understandably pulling their hair out, literally, about what to do with Amy wandering the corridors at times when they can't staff the nursing home, and they've got a duty of care to look after people. So the chemical restraint idea is not such a bad idea, and we all know that now with dementia in particular that there's a behavioural disorders aspect, and risperidone is indicated for that, or can be indicated for that. I think the first thing that I'd do, though, if I was called to see this person and I hadn't put her on risperidone, would be, or even if I had perhaps, would be to stop it again. Because I'd think that maybe some of the side effects there, especially being incontinent of urine, would probably be related to that. The fact that she's got cramps and waking up and having poor sleep maybe is due to the rivastigmine. So I guess my first impression here would be that there's a combination of drug reactions, and I'd be keen to figure out what to do about that. I think I might comment to two people in this situation, and instead of just throwing to my colleague Anthony, I might sort of even ask Chris as a pharmacist to do a residential medication management review and come in and say, I doubt that she's only on warfarin. If she's on warfarin, there's probably other drugs, and there could be a whole lot more confusing things. Having said that, I'm sure I would have checked a lot of reversible causes again, the urinary tract infection, etc., etc. But Chris, I'd probably ask.
Look, if she's only on 3 drugs, that may go a long way to explaining how she's made it to 83. But having said that, she's on 3 crackers, isn't she, really? I worry when I see warfarin in a nursing home patient with dementia and with a dementing illness, and on antipsychotics. You always worry about falls, things like subdural hematoma is something you have to concern yourself with. There's a lot of debate, of course, about the role for antipsychotic drugs in the management of behavioural disturbance of dementia, whether or not they do indeed increase mortality. Pretty clearly there's some evidence to say that they do, but then you have to ask yourself, compared to what?
Yes.
Indeed, you know, if they weren't getting antipsychotics or some form of pharmacological assistance with their agitation, what would their outlook and their prognosis be like? I suspect quite similar. Certainly the evidence now to say that these drugs cause a greater incidence of cerebrovascular events than their predecessors is starting to look a bit shaky, and in fact I suspect the risk is pretty similar for most of them. So
would you be suggesting intermittent use of risperidone in any way, or is continuous use more effective and therefore safer? Well, there's a point for debate, and you hear different schools of thought enunciated. One, of course, is to think that maybe the answer is to provide some facility for the nurses in the care setting to be able to choose smaller doses of the drug, or to omit doses if they're not needed, and perhaps to try and reduce the longitudinal burden of psychotropic drugs that Amy's going to have to carry around going forward. But there are different ways of looking at it, and I'm sure there are different schools of thought.
I'm sure that the dose of risperidone is clearly important. And I guess if I was starting risperidone, I'd be starting, as we've said before, with a sniff of the bottle, really, but a very low dose. But I suppose the other question you might say is, you know, the stroke risk related to risperidone itself, as opposed to the anti-stroke properties of warfarin. I mean, you know, how much are you robbing Peter to pay Paul?
Yes, that's right. We have a faxed question from a mental health nurse in Queensland who says it can sometimes be difficult with antipsychotics to tell side effects from symptoms. Are there any guidelines in working this out? Anthony, have you got any magical guidelines? I mean, I just think this is a very, very important issue, but quite complex, isn't it?
It is a very important issue, especially when you consider that it's common for people to be on a number of different psychotropic medications. I suppose, Chris, I'm of another school in that particular issue, and that would be to have a very small amount of medication which is given on a regular basis, and be very cautious about increasing it. And I think that actually also applies to the question that's come through. It's very hard to know where you're at if different medications are given at different doses the night before, according to the perceptions of the nurse who's been seeing that particular patient. An appreciation of what the effects and the side effects is much easier if there is some consistency in what is being given to the individual patient. I think as to is there a guide for which is side effects and which is effects, that really comes down to having a clear idea about what you're trying to treat.
And does it require clinical judgment and appreciation of the course of the illness?
It does. It also requires you to lay hands on the patient. You have to see whether they've got that rigidity, that cogwheel rigidity. You have to see what the term is. You have to have an idea about their postural blood pressure, whether you're causing that to drop and whether that's going to cause them to fall.
Yes.
Could I just add too that these people have a lot of difficulty in some cases verbalising or describing their symptoms, and it's important not to overlook the fact that these people just might be hot or cold or tired or hungry or thirsty or annoyed or sad, or the whole gamut of human emotion that we all experience, but they're unable to say those things the way you and I can.
The other thing that comes to my mind is that the time course of the behavioural disturbances that you see, it's going to change over time. It's not a consistent sort of a thing. So it's really important, if you actually are prescribing medication, whether it is or isn't causing side effects, to actually reassess the situation fairly frequently, because patients' symptoms do change over time. Dementing illnesses are degenerative, so you actually do see fairly well-staged changes in behaviour. And what's appropriate now might not be appropriate in 3 to 6 months' time. So you do need to make sure that you've got that follow-up and review going, so you're not unnecessarily medicating people along the way. I'm not advocating that you don't use a treatment when it's appropriate, but don't use it if it's no longer needed.
Well, I think all that's very wisely said. Now, our final case study for this evening is Nick. Nick is a 26-year-old man who was diagnosed with schizophrenia when he was 20. He'd been previously violent and aggressive and had attempted suicide a number of times. He's been prescribed olanzapine, but he's not been taking it lately. He often drinks heavily and has been frequently using cannabis. Now, one of the issues with Nick is also that he's non-compliant. Anthony, could you perhaps comment on this vexed issue? It's so difficult to manage in practice, but it's clearly an area you spend some time in.
Yes.
What are the issues and how do we deal with it in terms of drug safety as well?
Nick's situation is all too familiar, unfortunately, and it really does come down to an issue about getting him an effective treatment which he is able to take. And that really depends on a number of other things. The support that you can get to Nick, whether there are people that can help monitor his medication or go out and check up on that safely and without provoking huge amounts of family discord or things like that. It sounds as if Nick may have had a reasonably long course of his psychotic illness, and for people in his situation, a trial of clozapine should always be thought of, because clozapine certainly is the most effective of the antipsychotics. It also has positive benefits from the point of view of ameliorating substance abuse and decreasing suicidality. So there are some real benefits in prescribing an antipsychotic like clozapine, despite its many side effects. However, it's a tablet, and as Chris said earlier, treatment's only effective if you actually take it. And this can be one of the vexed issues of getting an antipsychotic appropriately for the patient in a way in which it actually gets them. And so that may mean a depot medication.
Yes.
And some form of community treatment orders.
Now, one of the things that can contribute to non-compliance, non-adherence in this, particularly in this population, is sexual dysfunction.
Yes.
Could you please comment on what the implications might be and the comparative frequency of this side effect in the different psychotropic medications?
Yes, Nick is a young man, and young men really are interested in a relatively small number of things at times. Sexual dysfunction is a real problem, particularly for antipsychotics that raise prolactin, so high potency antipsychotics, and for the SSRIs. So they can be a problem for across the whole range, I'd have to say, but in particular they're the drugs that are well known to cause these problems. The difficulty is finding out, knowing. So it's something that in my experience you have to ask.
They won't tell you.
They won't necessarily spontaneously reveal that they are having a sexual
How do you
problem.
ask the question?
It's good to know your patient in this particular thing, but I would commonly lead up to it from the point of view of girlfriends, if I know they have a girlfriend, or to ask them quite boldly at times that one of the reasons why people like stopping medications is they have problems with sexual function or impotence, and going through those words. Often that is one of the issues at hand for non-compliance.
Right. Jonathan, in your practice, have you had to deal with young people like Nick being non-compliant with their psychiatric medication?
Not as much, because I must admit the community treatment orders are usually invoked at this stage in order to get them into areas where they're much more likely to be compliant. However, one of the interesting things with this, I think we mentioned that he has hepatitis C, is that right? Did we decide that he was...
I think we left it out in the end.
I think we left it out in the end. But
Too complicated.
We have now. So one of the interesting things is that I suspect if you looked at a lot of schizophrenics in the younger populations, that they are hepatitis C positive.
Yes.
And one of the ways maybe to gain his some degree of consistency in his treatment would be to suggest that he gets treatment for his hepatitis C. One of the spin-offs might be that your clinic, if you're able to provide the regular weekly injections, is to be able to sort of work him through a process of coming along. By doing that, it's possible that we could then maybe get him onto a depot at some stage. Yes. So that would be where I would see a general practice aspect to this case.
I think one of the issues that you're raising there is that medical illnesses are very common. In fact, they're more common in this group of patients and people with mental illness, full stop, than in other groups in the population. And that flows through into increased morbidity and mortality for this particular population group. So the working with general practice is a very, very important thing. And this is one of the problems with our health systems, is that we still have some very basic
hard
communication issues.
Yeah, and I think a much more overt reason for non-compliance with these medicines, and especially in young people, but in all ages, is the metabolic syndrome you alluded to right at the beginning of the program. If these medicines make you fat, you know, you're not interested in taking them. So are there medicines around now that you're adding in as polypharmacy but might help with the weight gain issues? I mean, I heard some people use, is it lamotrigine?
Topiramate would be
topiramate.
the one. I suppose I would go back and look at what, particularly the antipsychotics we're talking about here. So there are antipsychotics now that have a very low risk of causing weight gain. So there are some that are certainly very well identified as causing, as being very likely culprits for the weight gain, but also trying to choose the ones which have the lower likelihood. But going back to diet, exercise, these are people who often are very neglected and who stay very much within a very isolated existence. Trying to bring them out with some psychosocial program, some rehabilitation or recovery program is very important. Other pharmacological approaches, metformin, I suppose, would be one which is used on occasions. But really, we're talking about the food that goes in, which is too often is of appallingly low quality, and too little exercise and too long spent sleeping on the bed.
Yes. Would that be the same for the weight gain that occurs with the older drugs like tricyclics? That something like exercise is a useful intervention, or metformin?
Again, I suppose first go back to what are the other parts of the equation, which is putting on the weight.
Yes.
It might be that a change of an antidepressant, if that's not going to destabilise that person, or good heavens, reviewing the medication that the person has been on for perhaps many years is a very good idea at this particular stage, and seeing if there are other ways of approaching that problem.
I think with the increasing availability of so many different drugs, we certainly have options. Christine, did you have a comment?
Yeah, I actually had a comment about psychotropics in general, and in fact across the board, across most of the drug categories we actually have, there's a reasonable number of drugs that are actually implicated in causing significant weight gain and doing it in a relatively short space of time. And there's also a significant number who might not cause you to gain weight in the short term, but certainly over a longer period of time you see similar sorts of changes. So some of the SSRIs, for argument's sake, short term you're looking at relative weight losses or being relatively weight neutral, but long-term use you might see significant weight changes. So it's important along the way and given that this population as a rule are generally poorer, very poorly cared for, their self-care is fairly poor, their access to services is relatively poor, the identification of general medical illnesses is poor, and the follow-through is poor, that it's important that you put in place a lot of the psychosocial stuff again across the board, because it's not just antipsychotics or just the old tricyclics or just mirtazapine that causes weight gain.
Yes.
There's across the board we see it.
Yeah. I think that's very, very true. I guess the issue, though, is that we have a rural audience tonight, and maybe in places that are non-metropolitan, it's not so easy to access those sorts of services. What about telepsychiatry? I mean, how accessible is that now to people who need these sorts of non-pharmacological interventions? But can they get it over the internet?
Certainly there's some good programs in the areas of anxiety and depression, which are accessible, widely accessible over the net.
Like the programs on Beyond Blue and so on?
Beyond Blue is a good place to start for those programs. Google depression and it will come up. The availability of telepsychiatry really varies greatly from place to place in Australia, and it's, I'm sure our viewers have a much better idea about what they can get than I do.
Right,
that's not our big Australian, is it? The one starts with T and ends with A, has Elstree in the middle of it?
Well, I suppose it all depends on where you are, about what services you can access. Now, before we go to our take-home messages, I wonder if any of you think there are any burning issues that we've forgotten tonight or we still need to bring up? You know, I think there's so much we have to cover. It's such a huge area, isn't it? But we've dealt with paediatrics, we've dealt with geriatrics, we've dealt with pregnancy. I mean, one of the things I'd like to perhaps briefly talk about is compulsive gambling as an issue associated with some of the Parkinson's drugs. Have you seen that with any of the other drugs that affect the brain?
I haven't myself, but I suppose gambling is one of those behaviours which is there with substance abuse in the background of many of our patients, and it's a matter of asking that question,
yes,
which will unveil what is a real problem. I suppose for me, the thing that we haven't talked about is that comorbidity, that fact that one condition goes with another condition, which often goes with a substance abuse problem, and getting a handle upon those multiple different problems is a challenge at times, but you should always inquire about those other areas of illness.
Well, on that note, I think we might hear what your take-home messages might be for our viewers tonight. So, Jonathan, what would you like to say?
Sure. I guess my first take-home message is ensure the correct diagnosis. I think that we've heard tonight that there's lots of different medications for lots of different problems, and I think understanding that you actually are confident in your diagnosis is one of the most important things. I think the second thing is to be familiar with a particular drug in each class. whether it be the SSRIs, whether it be the SNRIs, whether it be the NASAs, all these different acronyms, but I think they mean something, and we've heard that it's very important to understand the prescribing information related to each of them and how they interact. Most important.
Chris?
Well, it's an old message, Geraldine, but it's first do no harm. Be conservative. Think carefully about what you're choosing in terms of the dose of the drugs that you use, the way you're going to combine them together, the monitoring you're going to put in place for the patient to ensure you're picking up on adverse effects as they evolve. And also, I'd point out it's very important not to let that conservatism prevent you from using medications when they're very clearly required. So don't hesitate to use medicines when they are needed.
Christine?
Well, I think it's, as Jonathan said, important to know your drugs and what you're actually prescribing, and being aware that we're forever getting new information about medications. So what was good yesterday might not be good today, and we need to keep up to date with that. And if you don't keep up to date, you need to know where to go to get the information when you need it. So making sure that you either do your reading or you know where to get the new information, and make sure that your information is current.
Very true. And Anthony?
Geraldine, I think I'd say try and keep it simple. Try and minimise the number of different drugs people are on, and if one isn't working, then stop it and trial another one. And of course, the best way of avoiding drug interactions is using psychological treatments if you know how to, or those that is available to you.
Yes. Well, I'd like to thank you all very much for participating tonight. Jonathan, Chris, Christine and Anthony.
Pleasure.
I hope you've enjoyed this program on psychotropics, what's safe and what's not. If you're interested in obtaining more information about the issues raised in the program, there are a number of resources available on the Rural Health Education Foundation website at rhef.com.au. And don't forget to complete and send in your evaluation forms, and please register for CPD points by completing the attendance sheet. Finally, our thanks to the Department of Health and Ageing for making the program possible. And thanks also to you for taking the time to attend and contribute. I'm Geraldine Moses. Goodbye.